Hello, everyone. I am Cheryl Zimmerman. Welcome to the Be Well in AL webinar, a coalition to promote medical and mental health care in assisted living. I know some people are still going to be joining as we're getting started, but we've got a lot to talk to you about today, and we're very excited for this overview and essentially this invitation to join our roundtables as the Coalition to Promote Medical and Mental Health Care in Assisted Living. We're recording the webinar, and we ask you to mute your microphones when you're not speaking, but we will have time at the end of the presentations today for discussion and Q&A is being whatever gets put in the chat. So we hope you will put things in the chat today. So this is a launch webinar that is hosted by University of North Carolina, Chapel Hill, AMDA, and SEAL, the Center for Excellence in Assisted Living. But already many different organizations are already involved in this effort, as evidenced by the overview of the webinar, which I'm going to show you next. This is the overview of what we're going to be doing today. So you see already there's a lot of organizations that are supporting this topic and helping to launch the coalition. I'm going to start by talking about the rationale and aims of the Be Well in AL Coalition. I'm at University of North Carolina, Chapel Hill. Then we're going to hear perspectives from Center for Excellence in Assisted Living, AMDA, ALNA, Alzheimer's Association, and also providers and advocates, representatives of Evergreen Estates and California advocates for nursing home reform. And we are going to have time at the end to talk about next steps in joining the coalition, discussion, and Q&A, again, by things that you have put in the chat throughout. The very fact that you're even attending this launch webinar means that we're kindred spirits. We're all here because we're wanting to promote quality in care and outcomes in assisted living. And the fact that this is a pretty widespread sentiment is evidenced by the fact that over 200 people signed up for today's launch webinar. Certainly not all are necessarily going to be on today, but there will be follow-up with them and then the growing numbers of people who said that they're interested in joining this coalition. Certainly I'm learning more about it. So why are we even having a coalition? It really boils down to whether there's cause to promote change in assisted living. And earlier this year, we convened a host of people to discuss the extent to which there is cause to promote change. This was a paper that was published earlier in 2020 based on 2 retreats with very diverse leaders in assisted living. I'm sure many of these names are going to be familiar with you. You can see their affiliations, but there were representatives from National Association for Regulatory Reform, CARF, ALNA, Senior Living Operators are here, Pioneer Network is here, Alzheimer's Association, PHI, Leading Age. You see a lot of the leaders, the thought leaders, and the people who are implementing and making a change in assisted living. So why a coalition? Because we had 2 retreats with this very diverse group of experts in the field. And one of the summative points was there was an imperative to reimagine assisted living. The next summative point that I thought was most telling was the agreement, and actually pretty vehement agreement, that today assisted living is not as it was intended in the past, and it has to be reimagined for the future. Well, through these retreats, we ended up coming up with 5 different areas where change is indicated and 20 potential evidence-based solution areas where there actually have been efforts that have been made to focus on some of the reimagining that was identified. All of these areas need attention. All of them could be the purview of our coalition and ultimately can be, but we have to start somewhere. And we are proposing that we start with the residents. Why does this make sense? Well, it makes sense, first of all, thinking about who is it that lives in assisted living. I know this is a seasoned audience. We've been talking about for quite some time, people who live in assisted living or nursing home residents from a decade ago. There's a lot more acuity, both medical, cognitive, and also affective acuity. Alzheimer's disease and other dementias are highly prevalent. And we now know that assisted living is the largest provider of residential long-term care in the country, including for people with dementia. I can say that again, largest long-term care provider. Sometimes people have said, well, there's more people in nursing homes. People in nursing homes are also there for post-acute care. So if you look just at people who are getting long-term care in a residential setting, it's happening in assisted living, and it's very notably happening for persons with dementia. So again, why are we starting with residents? Well, it's because what assisted living is when you're talking about all these increased acuity needs and cognitive and affective needs. Assisted living began with a social focus, presumably, with some thinking that it's not a healthcare setting. That really was not what was always intended. And I know some of the perspectives we're going to hear today will focus on that. Tremendous amount of variability in assisted living. I don't know if you know the numbers. I know the work being done by Paula Carter and her group in Oregon. They've identified there's basically, I think, 350 different flavors of ice cream, if you will. There's 350 policy approaches to what assisted living is across the country. And then why else start with residents? It's because who's working there? Who's providing their care? There's limited medical and nursing provider presence. Half of them have an RN or LPN and half don't. And very few have primary medical care on site. So the direct care staff, of course, are the ones who are doing the majority of the hands-on care. Is of course the case in nursing homes, but most states or many states do specify at best minimum staffing ratios, and only a quarter of them require the direct care workers to have at least 11 hours of training. So it's not a workforce that is highly skilled in the provision of medical or mental health care needs. And so not surprisingly, there have been concerns about medical and mental health care and assisted living. We know there have been concerns about infection prevention. Kelly Thomas and her group in Brownlee identified 17% increased mortality during the time of COVID. There's been concerns about medication use, poor communication with staff when a change in condition occurs. And then when there's concerns about care, there's also concerns about outcomes. So what you see listed here are areas that there's been dialogue about whether some of these could be avoided, reduced and avoided in total if care had been modified. So this isn't the first time we're talking about the need for medical and mental health care and assisted living, and the field has evolved. There's an increase in nursing presence. I showed you the data that roughly half of places do have an RN or an LPN on site. And there is some integrated medical care, but the problem is there's not been data driving or informing what that evolution should look like. And when it comes to assisted living, it's not the easiest thing to do, or it's not necessarily that straightforward. Because of all the variability in assisted living, there's really, until now, been no guidance about optimal structures and processes of medical and mental health care. And we really have to be mindful, recognizing that this is assisted living, this is not nursing homes. And there's been concern that the more we talk about medical and mental health care, there may be concerns about assisted living becoming too medicalized. So the upshot of what we know and how the concerns have evolved is kind of publicized in a Washington Post article that came out just the weekend before last. And this report garnered almost 500 different comments in response to the report. A lot of the comments were positive about assisted living, about the good care, the good people, the need for it. But a lot of the other comments also talked about the challenges related to variability, about needs for supportive care, and about healthcare, all of which are relevant today. So I just put a slide with 3 of them right now. One of the comments said, there's no consistent assisted living definition. Saying assisted living is like saying hotel. It could be a small roadside dump. It could be a 5-star luxury establishment. And then now talking about the supportive care. I found that the term assisted living means different things in different states. In Pennsylvania, where my husband's grandmother lived, a person assisted living would receive help with their activities of daily living, like dressing and toileting. In Massachusetts, where we now live and where my mother-in-law moved to be closer to us, people in assisted living were expected to be able to do those same activities of daily living with no help. This caused us no end of hell. And now then the last comment more related to healthcare. My mother benefited from assisted living for several years. I think it improved her health and well-being. But as her health deteriorated, she needs far more care than she's getting. She went to a skilled nursing facility, but Medicare threw her out. So she's 100% bedbound in assisted living and requires an aide to feed her. It's horrible. The facility and staff really aren't equipped to deal with a bedbound person, but there's nowhere else to go. So a key quote from the article is here. The nature of the clientele in assisted living has changed dramatically, yet there are no widely accepted standards for addressing their physical and mental health needs. This new report presents recommendations from experts, including patient advocates, assisted living providers, and medical, psychiatric, and dementia care experts, with hopes the recommendations will become a new standard of care. So this report gives us legitimacy for our coalition to promote medical and mental health care and assisted living. This is timely. It provides a clear focus and a very clear direction. These recommendations were published in September in a JAMA Network Open. I know that you received a handout, a one-page handout that summarizes all of the recommendations and includes a link to this paper, which I do encourage you to look at. So again, just like if we needed diversity when we were thinking about what the status of assisted living was, we need diversity if we're going to be putting forth recommendations for medical and mental health care. And these names here that you see, the authors, the panelists, there was represented a lot of diversity. So here's their affiliations. But it involved in this panel clinicians, assisted living operators, ALMA, Assisted Living Nurses Association is here, AMDA, Alzheimer's Association, Advocates for Reform, National Consumer Voice is here. So very diverse panelists who are working in the field, who are regulating the field, who are being administrators serving in the field, representing what we need. I have two slides very quickly to show you how these recommendations were developed, so you understand what went into the secret sauce, if you will. A research team, myself and my colleagues at University of North Carolina and elsewhere, Brown and Oregon especially, we compiled a host of items that could potentially be important to medical and mental health care based on literature, regulations, guidelines within assisted living communities, an advisory panel, inputs of panelists. We came up with 183 items and we grouped them into categories, like categories within them. Then we had 3 rounds with these 19 diverse panelists. And in their round, each round, they anonymously rated the items in importance and feasibility. Anonymity is key. I really stress it here because no one person knew what someone else was rating. So it's not as if the voice of a clinician was going to be rated any more highly than the voice and opinions of someone representing an advocacy group. So they rated the importance to quality of care, and they rated how feasible they thought each of these 183 items were, recognizing how variable assisted living is. That was round 1. Delphi panels of subsequent rounds. So in round 2 and other rounds, we asked them to rescore items if we felt that the items weren't clear. And also a few things we wanted to know their thoughts about. Could we actually put forth metrics and cut points to actually say absolute numbers? And then we discussed the final results, and then we put them all together and see what came out in the wash, and ultimately compiled all the items that met the established cut points for importance, which is 7 or more out of a 1 to 9 scale, and where at least 75% of people agreed on 7 or more. This is a very standard, highly regarded and widely recognized cut point and consensus cut points. And one last slide of what the project looked like. Here's an example of, in blue, the indented ones. This is like one item in each of the 6 different categories. The categories are the black items. So, for example, when they were rating the importance and the feasibility within different types of community demographics or issues related to administration of assisted living, one of the items was whether they had memory care unit or designated dementia beds. And for that, in all items, they rated how important it was to quality care, whether it would significantly affect outcomes based on extent of need and benefit, and whether it was feasible in none, some, or all communities. So what were the recommendations? Of these 183 potential items of importance for medical and mental health care, we were maybe shocked is overstated, but we found it pretty remarkable that 43 items achieved consensus cut point from this very diverse group as being important to quality of care outcomes, that at least 75% of the people, of the panelists rated it 7 or more. This is a snapshot of the handout you all received. This has got all 43 of those items, and at the bottom, this is the handout that at the bottom, it gives you a link to the actual paper, the JAMA paper. I really do encourage you to look at it because we not only talk about the 43 items, we talk about the other 140, which are also important. Don't want to say that they're not, they just didn't meet the cut points, but in some cases they may be highly relevant. So I'm now going to do a really quick overview of each of the different categories, but today's intent is not to dig into the recommendations themselves. It's really to be focusing on the launch of our webinar and talking about next steps, the launch of our coalition and next steps for the roundtable. But I at least do want you to understand what these recommendations look like if you just look at a snapshot from each one. So of the 43 recommendations, 11 of them related to staff and staff training. So I'm going to have 5 different slides. They're all going to look just like this, but with different examples in each of the rows. So the first column, importance mean, that was the thing that could be scored between 1 and 9. All of them will have a 7 or higher because that's what was important, what needed to happen for it to be important. Percent agreement had to be at least 75% for consensus, and then the feasibility, 1, 2, or 3, the extent to which it was feasible, and none, some, or all. So just as an example, that very first row. And in red for every one of these, I've highlighted in red the highest rated item. The panelists determined that training for any staff on person-centered care was the most important when it came to staff training. It was scored 8.89 out of a 9. 100% of people felt it was important. And they also felt that it was feasible to do this in almost all communities, 2.89 out of a potential of 3. There's 3 items here that asked for numbers. One, like the direct care worker to resident ratio, that's the second one. And then a couple of items related to the percentage direct care workers. And we asked staff whether the panelists, whether they could give us a number, and they said, no, we can't. And I like to show this slide because it really shows you, I believe, how feasible and pragmatic the panelists were. Because we said, can you tell us what the ratio is? And they said, no, we can't. Because if we're going to start talking about ratios, we need to better understand the acuity, what care needs are, and what is the evidence. So we need more research. And can we talk about what is the percent cut point we're looking for people who aren't contract staff or who should be full-time? Same types of comments. We have to be realistic here. We have to realize there's staffing challenges, there's different employment conditions. So the jury is out. We're not ready to talk about the actual percent of direct care workers who aren't contract staff or who should be full-time, because this workforce may need more flexibility than that. So both of these need further research. The next category, 9 of the 43 recommendations had to do to nursing and related services. The highest rated one of this you see again in red, provision of routine toenail care on site, 8.16, 80, almost 90% of people agreed, and it was feasible in between some and all communities. Next recommendations, 10 of the 43 related to assessment and care planning. There you see the top 2 in red, that the resident should be present during assessment and care planning, and that communities conduct formal cognitive assessments as part of resident assessments. The next category was policies and practices. There you see in red the 3 most highly rated items: policy procedure about aggressive or other behaviors, informing responsible parties if an emergency department visit occurs, and having discussions about advanced directives and documenting them, not requiring people to have advanced directives, but having discussions about them. And the last category is medical and mental health care clinicians and care. And here, the highest rated item was all offsite medical mental health visits include post-visit notes. I want to one more comment about this feasibility column that you've seen in all of these. This is their perceived feasibility, and I think it was probably pretty realistic, but we do have data on the feasibility of many of the items, many of the 43 items. In an ongoing NIA-funded project, and by the way, all the work I presented right now is through NIA funding, we have data from 250 communities across 7 different states that have been participating in a study, and I wouldn't be surprised if some of the people on this webinar, if those are the communities that you own or operate, and thank you as always for your participation. We had data for 26 of the items from almost all of the communities, between 150 and 250 of the communities. Critical finding, 77% of the items were already being practiced in at least 3/4 of the communities, including every one of the nursing and related services items. So bottom line here, the recommendations that we came up with, they are not aspirational. They are feasible and realistic. Again, if you will, I believe, and we believe the organizations have already been thinking and putting together this coalition. This gives us excellent grounding from which to start. Last few slides are some observations after we looked at all of the recommendations, and we said, you know what, they really are relevant for assisted living. Very much to a person, they talk about different things that are important to assisted living, like training in person-centered care, importance of conducting care plan meetings and advanced directives. They also recognize that this is where people with dementia are living. And as you saw, some of the recommendations related to training on dementia and cognitive assessments. I already comment about being how pragmatic they were, recognizing the diversity of assisted living. And lastly, none of us can be working in this field if we don't talk about the fact that we need to be having recommendations that are related to the workforce needs, because that's really the critical need. So this is where we're at now. Our next steps, affecting change in practice and policy, the Be Well in AL Coalition. The aim of our coalition, and this is why you're here today, is to develop a diverse national coalition to affect change in assisted living practice and policy based on evidence and best practices. We are going to do this by launching with the medical and mental health care recommendations for all the reasons I just gave. We will be convening 2 action-oriented roundtables, one focusing on operation and one focusing on policy. Hopefully you're represented in this include list. We want policymakers, owners, operators, professional provider, healthcare and advocacy organizations and individuals, residents and family members, critically relevant, researchers and others, everyone to be part of this coalition. We see ourselves developing products through the coalition and ultimately spreading the word and effecting change. My second to last slide, our next steps, is we are soliciting some roundtable leaders for these roundtables. Already we've got some interest from some folks. I've talked to some of you who are on this webinar. Please reach out to us if you want to be one of the leaders. That's what we need. It takes a village to have a coalition. Alicia Graff, who's the person who sent you the invites, if you email her with your name and interest in having a very, very active role, you'll hear back from us for sure. Everyone else will also hear back from us because we will be providing Zoom registration links to participate in the roundtables. And I will say, we hope that you will sign up for one or both roundtables because the efforts surely will be integrated, operations and policy. So with that, let me turn to the really critical part of today's launch, is hearing perspectives of the organizations that have already been highly active in this area. I will be turning it over person by person to first Lindsay Schwartz representing SEAL, Barb Resnick representing AMDA, Margot Coons representing ALNA, Doug Pace representing the Alzheimer's Association, Pat Giorgio from Evergreen Estates representing providers, especially providers of smaller communities, and Tony Chicotel, who's going to be representing advocates. Each person will be talking for about 5 minutes. I'll be a timekeeper, and we're going to allow time for discussion and Q&A and chat. So thank you all very much for your time and attention. I'm going to turn off my camera and invite Lindsay to turn on her camera and talk to us from the perspectives of SEAL.
Thanks so much, Cheryl, and thank you everyone for being here. As Cheryl said, I'm Lindsay Schwartz. These are great recommendations that the SEAL board supports. In fact, many of our SEAL board members and advisory council were either part of the research or involved in it. And personally, I felt this process was a thought-provoking exercise and the results were very interesting. In fact, we were talking about them many times during SEAL board meetings. So it's nice to have this roundtable to discuss more in person. SEAL continues to support AL regulation at the state level and feels strongly that these recommendations help identify key areas to focus on and to continue to support residents as acuity has increased and will likely continue to increase, and also opportunities for improvement. As we saw during COVID-19, as Cheryl mentioned, a lot of healthcare was provided in assisted living. AL is a model that focuses on person-centered care. I realize you all know this, in quality of life and a home-like environment where individuals happen to receive healthcare. I firmly believe long-term care is an important part of the healthcare system, and healthcare doesn't mean assisted living is all of a sudden a hospital or a skilled nursing, or as Cheryl used the term, medicalized. But we have to acknowledge that healthcare is happening in assisted living. We know this from COVID-19, and some of it in some states is basic as putting on a Band-Aid or coordinating care or medications. And in other states, they allow a lot more in-depth types of medical care. We're really a discussion that's come up numerous times on SEAL, and the SEAL board fully agrees that gone are the terms of social versus medical model. AL really provides holistic care that includes mental and physical well-being, and really could be a model for other types of healthcare and long-term care settings. To provide this vital care, though, and Cheryl touched on this, we have to focus on workforce. We all know AL was having issues prior to the pandemic, and it's only become worse with the shortages. Policymakers need to focus on funding and initiatives to recruit clinicians, like loan forgiveness, scholarships, apprenticeships, and other things that we can get direct care workers, like health professionals opportunity grants. Providers have a role in this too, ensuring that AL is providing good jobs, good pay, good benefits, good leadership, and many other things that lead to that. Some things that SEAL can do and will do to help support this work is work on what a good job is and ideas to address the workforce shortage and help to improve retention and recruitment. Help disseminate evidence-based practices and policies, as Cheryl was talking about through the research, and help with that implementation. SEAL does a great job already and will continue to collaborate with researchers like Dr. Cheryl Zimmerman to evaluate programs and practices, and continue to encourage researchers to ensure all stakeholders are at the table, staff, residents, and families, and also to ensure why policies and regulations are being made, that those individuals and important stakeholders are also at the table. SEAL can also help with disseminating these recommendations to policymakers, as Cheryl had mentioned, around one-pagers and briefs to help with development of policy and funding that makes sense and really continues to support assisted living. And on behalf of SEAL, thank you, Cheryl, for letting us be a part of this and also sharing SEAL's views on this.
Thank you, Lindsay. Thank you very much. Next, turn to Barbara Resnick, who's going to be presenting the perspectives of AMDA, the Society for Post-Acute and Long-Term Care Medicine.
Yes, good afternoon. It is now, at least for many of us. And I can't say again how much we appreciate your joining. The perspective of AMDA, as you probably would guess or imagine, has really been around I'm going to say medical care, health care that's provided in assisted living. And it's really been driven by the Assisted Living Subcommittee, which started in 2011. And I believe Dan Hamowitz is on the webinar, and he was intimately involved with this. And the subcommittee is very much a multidisciplinary group of healthcare professionals, which really focus on the opportunities to promote the access and the delivery of high quality care to individuals who reside in these settings. Obviously, since 2011, things have changed a lot, but the committee reviews and monitors existing research, practices, policies, and resources, and proposes recommendations to the AMDA board to then work on establishing and prioritizing initiatives to improve education, advocacy, information, and professional development in these settings. To this end, the group has worked on a variety of projects. We have had consensus summits, many of you may have participated in. There was a white paper developed to address healthcare and assisted living. We've developed guidance for infection control in assisted living, and then done a multitude of presentations, described different models of care. We've surveyed our membership about the roles in assisted living, and I think there's a lot more healthcare being provided than we sometimes even know about. And we considered what quality measures might actually look like in assisted living, and developed and shared drafts on the optimal role of medical directorship in these settings. I will tell you that's probably one of the highest areas of debate within this group. So currently the group really has been focusing on ways to integrate healthcare into these settings to make sure it is accessible and optimizes quality of care. So thanks for joining, and we do hope you'll all join the roundtables.
Barbara, thank you very much. Next, Margot Coons is going to talk about the perspectives of AMDA, the American Assisted Living Nurses Association. Margot, I hope you can hear us, perhaps not. And if not, maybe I will go next, if that's okay, to Doug Pace. Doug, representing the Alzheimer's Association. Are you ready to present now?
Sure. Hi, everyone. Thanks, Cheryl. And thank you for the opportunity to be here today and the opportunity to have been one of the participants of this consensus panel. And, as Cheryl and others have commented, this Delphi process, it worked extremely well in hearing the various voices of those connected to assisted living, and the results and the amount of consensus is really encouraging. And what's also encouraging is that these recommendations support and are consistent with other national organizations and initiatives. For example, the Alzheimer's Association updated our dementia care practice recommendations and a special supplement of the gerontologist. And those recommendations are for all professionals working in long-term and community-based care settings, including assisted living, because as Cheryl noted, over 40% of all residents in assisted living are living with Alzheimer's or other dementias. So we worked with 27 researchers, including Dr. Zimmerman, to look at the latest evidence around 10 topic areas, several of which are included in this study. So those recommendations are grounded in person-centered care, which begins with knowing the person. So when you know the person, you're able to meet them in their reality, and meeting them in reality creates meaningful engagement, and that meaningful engagement creates authentic care relationships, which ultimately builds a supportive community. So it's really about providing a consistent routine, putting the person before the task, and using every interaction as an opportunity for engagement. Some of those other topic areas include recommendations on medical management to highlight the role of clinicians like medical directors in assisted living and the important contributions that they make to care, especially as we see the acuity level and the care needs of residents increase in assisted living. And also the importance of detection and diagnosis, comprehensive assessment and care planning, dementia-related behaviors and transitions of care. And then two continuing themes run throughout all of those recommendations. One is around the importance of advanced care planning, and the second is around having a process for continuous quality improvement. So this study shows consensus on many of those same priorities. It was really exciting to see that 100% of all participants agree that there should be training for any staff in person-centered care. Now, we know that to provide good quality care, it must be focused on a person-centered delivery system versus a staff-directed system. And it's important to note that all staff, not just direct care staff, are trained in person-centered care. What we're talking about is a complete system transformation, similar to also what's being discussed in nursing home reform initiatives like the Moving Forward Nursing Home Quality Coalition, that puts the resident at the center of everything, not staff convenience. But to achieve that, it means that every person not only understands, but is trained on how to do that every day. And as important in staff training is dementia and other mental illnesses, which achieved a score of almost 97%. So again, we know the better trained the staff are, the more able they are to provide high quality care. And that knowledge makes them feel more empowered to do their job, and that will lead to more retention and less turnover. And it's also exciting to see that there was 100% consensus around the importance of advanced care planning, which should be documented at admission, that you had those discussions and then shared with the appropriate staff. And as Cheryl mentioned, another area that got 100% agreement is around direct care worker to resident ratio. Now, we all know that we have a lot of work to do in this area, but it's really exciting to see that everyone agrees on the importance of this. And then there was almost 95% agreement that having a resident as part of the assessment and care planning process is imperative. And over 80% consensus that there is a formal assessment tool for cognition and it's part of the resident assessment. We know that persons living in assisted living experience dementia-related behaviors. So having a policy and assessment process to determine the root cause of those also received 100% agreement. It's important to validate the person's emotions and understand the behaviors of persons with dementia is many times a form of nonverbal communication. So it's important to understand the root cause of that behavior, which many times might be pain, thirst, hunger, or sometimes just the need to use the bathroom. And lastly, there was great consensus around making sure that the resident and appropriate care partners are fully informed, including when there's a change in status and medication. And they should always provide consent for any new antipsychotic or opioid medication. And if all non-pharmacological strategies have not worked, and there is a need for a psychotropic medication, then the prescribing physician should always have a beginning and an ending date, along with a plan for gradual dose reduction. So thank you again for the opportunity to be here today. And I hope that these recommendations will inform practice, policy, and research to improve the quality of life and the quality of care for all residents living in assisted living.
Thank you, Doug. Thank you, Doug. And Margot, I see you've got your screen working now, and perhaps you've got your mute button. So thank you. We'd like to hear a few minutes from you as well, please. And you're representing the American Assisted Living Nurses Association.
Good afternoon or good morning, everyone. I appreciate the fact that you have all taken the time to join us. Sorry, I got thrown off the screen and could not get back in. I think in following up on what our colleagues have said, the biggest thing we need to look at from a nursing standpoint, which is what my group, the American Assisted Living Nurses Association, represents. We represent assisted living nurses, LPNs, and RNs nationwide, and we are the only group that does that in the country, that allows both levels of licensure to be admitted to the group. We have a certification program for nurses to become certified in assisted living. We have launched a new leadership training program with NYU, and we are moving forward to create more and more opportunities for our nurses to have access to excellent education. One of our biggest problems that all of us see is that getting our nurses out of the building to attend any kind of educational offering is often very, very difficult. So we try to do a great deal with e-blasts and webinars, etc. Some in conjunction with SEALS, some in conjunction with NCAL, and now with Farm America. And we have had very good success with doing that in the absence of having an in-person conference. I think the biggest thing that we want our nurses to do is to understand that even though we are trying to still maintain a quote unquote hotel-like atmosphere, we have to be aware of the fact that our residents have clinical needs. And we have to start our entire relationship with our residents by providing them with an excellent assessment. That assessment needs to not only include all the physical things and their advanced directives and their activities of daily living, it needs to include an in-depth discussion about their cognitive and psychological issues. Very often the best place to start is with the family. Start with them. They know the resident best. Have that discussion either prior to admission or during admission. You can do that one privately if you wish to, or you can include the resident in that one. Following gathering all that information that the families have to offer on normal activities, normal daily patterns, any kind of behavior issues and what works and what doesn't, we start out ahead of the game. By doing that and doing a depression scale of some sort, whichever one you wish to use, cognitive scores, we got BIMS, we got SLIMS, we've got Fulstein, we've got MOCA, pick whatever works that is scientifically proven to be accurate, and then you get your best scores and have a baseline for all of your residents. Don't wait for an issue. Assess them in the beginning, get a baseline so that when they change, you know. Then you need to include the resident in an assessment. They need to know what you're thinking, what you're saying. They need to know what steps you're going to take when you get to the service planning portion of that assessment service planning piece, and they need to be involved. They need to be kept up to date on changes that you've noticed. And we need to make sure that if there are new issues, depression is one of the least identified illnesses in the elderly population. It very often gets overlooked and people just go, oh, well, she's 80, So that's the way that goes. And we can't do that anymore. We need to make sure that our nurses are educated, that they know how to do an assessment. They have access to MOCA training. They have access to SLIMS, BIMS, or any other training that's out there. So as organizations, we're hoping that all the nurses that are involved in your organizations and ours will take advantage of the roundtables, see what tools they need, and see what we can provide them with. Thank you very much, everybody, for coming, and have a great afternoon.
Margot, thank you very much, Margot. And next I turn to Pat Giorgio, who is representing providers, the provider's perspective, especially providers of smaller assisted living communities. But I know your topics are going to be big topics and big comments. Pat, thanks for being here.
Thank you, Cheryl. It's good to be with everyone today. I'm going to take a really brief moment to tell a story. I turned 65 and I went for my first Medicare physical, and I was extremely offended when they asked me how many times I'd fallen in the last year. Believe me, the needs of a 65-year-old and the needs of an 85-year-old are not the same. So that was an eye-opener for me. And so even though I'm representing providers, I often see myself as an advocate for my residents and their families. It's extremely important that as we look at whether it's standards of care, however we want to define it, that we remember that older adults do not want to be defined by their age alone. I think that's critically important that we keep that in mind. They are individuals. They don't want to be housed according to their diagnosis. I know sometimes that's required with dementia, but we need to keep that in mind as we're looking at the whole person. We just need to be very cautious about standards of care based on those two factors, age and diagnosis, for example. So what I would say about assisted living from a provider perspective is that the strength of assisted living is that it is market driven. And by that, I mean customers and their family members can vote their approval or their disapproval of a community with their feet and with their checkbook. This creates diversity of services and a healthy competition. And I believe even designs of buildings are often driven by that to meet the needs of the consumer. The consumer is able to say to the provider what they want. I know that's in a perfect world. I know this world is not perfect. I don't have a lot of time to talk about low income assisted living, but that can be a challenge for those providers, although that doesn't mean they don't have the same desires to meet the needs of their customers. It forces owners and operators to be creative and to, as I said, to be responsive to the needs of their customers. I think that's one of the greatest strengths of assisted living. It is, however, like all private businesses, susceptible to market pressures. I know Lindsay talked briefly about labor shortages. That's just such a concern, especially since COVID pressures have been added to how we operate. Increased costs and decreased profitability all affect quality of care and quality of life for our seniors, which is a real concern. If providers do cut corners, quality of care is going to suffer. That is never acceptable, but it is something that sometimes happens. In those cases, those providers have increased their liability, and frankly, I think bad operators ought to be sued. Sorry, it's just how I feel about it. A few bad operators with poor quality of care end up affecting the whole profession and giving us a black eye. That offends me as an owner-operator. It raises the question of whether or not more oversight is needed, particularly federal oversight. In my 32 years of experience in assisted living as an owner-operator, I remain fervently convinced that federal oversight, additional oversight, is not needed and is not the answer to the challenges that we are talking about on today's webinar. Rather, I think states should continue to regulate assisted living. We know that assisted living regulations have changed, evolved over the years, and that there are much greater regulation in most states than there were 20 years ago. And that's probably a very good thing. So what I would say is that continue to look at all of these issues. They are critically important to the lives of our seniors, but just remember that one size does not fit all. Thanks.
Pat, thank you very much. And now, absolutely an illustration of last but not least, Tony Chicotel is here is joining us, representing advocates, and he is from the California Advocates for Nursing Home Reform. Tony, thank you for being here.
Oh, you're welcome, Cheryl. Thanks everybody for attending. I really appreciate the opportunity to speak and provide the consumer perspective, which is so critical. So I assist both assisted living residents and nursing home residents, and I see that there's really a lot of important differences, but I'm just going to focus on one. I think overall, without a doubt, assisted living is way more responsive to consumer needs than nursing homes, and Pat just mentioned that, which is great. That usually means to me that the quality of life overall in assisted living is better than in nursing homes. This is what we love about assisted living. It's more home-like. I think just generally it's more inviting. I think overall it's more resident directed, more focused on what I call the forest, which is quality of life, as opposed to the trees, which might be the bundle of discrete tasks, assistance with daily living tasks that are performed in both settings. I'm a fan of the social model. I don't want to lose that. Medical care, of course, is critical, but I don't think it should be central. Evolution is important, and I think it has to occur, but I'm really hopeful that we don't lose what makes assisted living so great. The one sort of criticism that I have is that I think sometimes assisted living is marketed to family members and the folks who signed admission agreements and write the checks. And it's sometimes their needs that take priority as opposed to the actual residents' needs. And this comes up in my work a lot with dementia care, where residents are locked inside, sometimes illegally. Over-drugging is a big problem, and that carries over into the culture. So sometimes the care can be really harmful. What the study that Cheryl led told me is that communication, reflection on how the care is going is so important, in the culture. And I've learned from some of the best providers out there that the goal of every consumer experience should be maximizing comfort and well-being of the residents. If the facility is inviting, residents don't need to be drugged or locked. Facilities don't need to be locked and residents don't need to be drugged. What matters most, of course, is the environment, the relationships, the interactions between staff and residents, the constant day-to-day routines. How is that provided? You don't have to be a mental health professional to provide incredible mental and emotional well-being for residents. I think assisted living does a superior job than nursing homes in this regard. There's still a lot of room for improvements, and that's hopefully what we're going to get at. Thanks.
Thank you, Tony. Now I invite everyone to put on cameras. We're done with our formal presentations. We'd like to have some discussion now. So especially if the panelists would put on their cameras, and everyone else who's here. And I had the chance to scroll through some of the names who are here. We've got over 100 people, more than 200 signed up for today's webinar. So we've got a strong group of real leaders. If you've scrolled through these names, I'm sure you're going to see a lot of people that you know and highly respect from the work they've done and the work they're doing. So we've got about 10 minutes for discussion. I expect the discussion could largely reflect the roundtables. How shall we move forward? Probably not so useful to get into the weeds and having big discussions about federal oversight or what one infection control procedure should be versus another. All very critical, important work that should be done through the roundtables and how to implement these. But if people are willing, and perhaps some of our panelists already saw some comments they would like to respond to have a dialogue going about next steps for the roundtable. But let me leave that with the introduction as my introduction to our discussion and open the floor here. Hey, I know many of you. This isn't a quiet group. Go ahead. I'm sorry.
Hi, Cheryl, it's Margot. I think one of the things that I saw in the comments in the chat section was that we weren't talking about families. I think right now, what we were trying to find out is what was going on at the facility level. We all know that without the families, we miss a great deal of information. So if we're not interviewing families, if we're not asking, that's a huge red flag. If you have someone who goes into an assisted living and calls you and says, you know, they weren't very nice, or they didn't ask me anything about my mom, or what did I need, that's a red flag. So I think all of us can promote that and say, you know, family is critical. I think we sort of take that for granted. I'm not sure that that's universal, but I know within my practice, it's always, what does the family need? What are they saying?
Yeah, and Margot, I want to notch that up one just notch is absolutely true. And that is why we want family members to be part of these roundtables. It's a pretty, that the residents and the families, I mean, those are really the two most critically important groups to be hearing from, and everything else should be able to circle around them. So yeah. And Dan, thanks, you raised your hand. That's a helpful way to do it. So you get to be called on.
Thank you, Cheryl. I'm trying to be polite. You know, the trouble is my wife told me just lay low and listen, and I really should listen to her advice. I just want to say a couple things, because, you know, I think I agree with everything Cheryl ever does all the time. That's the first thing. And I'm relentlessly practical. So I really love the idea of doing, you know, stuff that we can really accomplish and help people in assisted living. Now, this is a unabashed plug for what I've been doing with our little group, our assisted living group that, you know, spun off of Mike Wasserman's true Delphi group. And I'm not going to call us the Delphi group, Cheryl, because I know you're right. But two things. One is we put a lot of work into doing a medication optimization paper, which I don't know if that fits in here, but I think everybody would agree that, you know, better medication management helps everybody. So this is one of the things, and if you want me to send you the paper, I will. I think it's just a good thing that right off the bat can help people. The other thing, I saw that Heather Harrison was on the line, and Selena from CALA. And one of the things that we had wanted to do from the medication optimization paper is how do you turn it into chunks of education for assisted living communities? So I think this might be something that could really help the group. You know, Cheryl, you had written down education, which I think is so important. So all I'm saying is that, I mean, anything that I can do to help, I think this is a terrific initiative, and there's lots of opportunities.
Thank you, Dan. Thank you. And that's exactly what we're looking for, is we're looking for, and I saw a couple of chats I had a chance to look at quickly. We're looking for individuals. We're looking for organizations. We're looking for individuals who are or aren't representing their organization, because sometimes we know that's a heavy lift to have formal permission to represent your organization. But truly, this is a coalition, all hands on deck. This is not going to be, the recommendations themselves aren't hard to do, but we know the hard nut to crack is affecting change. So Dan, we know we're going to call on you and your group, and so many of the other people who are here, virtually everyone, and also we're in the chat.
Hi, Cheryl. This is Nirmala from Oregon, where Paula Carter works. You know, we have a severe workforce shortage here in Oregon, not just in assisted living, but also in behavioral health. And so really access to behavioral health consultation is a huge issue for assisted livings and others. One thing we have done in Oregon for nursing facilities is that I've developed a nursing home echo, a geriatric behavioral health echo, which was based on the one from University of Rochester in New York. So that could be one way to move forward. But essentially, it's the workforce very often that we have great trainings we want to offer, assisted living staff, but they don't have the time to take off and attend a training. So unless we built it into their licensing or their OA or our rules, it's very difficult to get people to come. And beyond the training, how do you measure the impact in terms of a policy or a procedure or practice that is adopted? And I'd love to be on one of the work groups. Thank you.
Well, with suggestions like that, you're obligated to be on the work groups. But those are exactly right. And there have been some conversation already how we might be able to use Project Echo for this. How we're going to have this be realistic for the workforce. And it is hard for them to attend training. So within the coalitions, with all these different voices and expertise, putting together practical plans, practical materials, helping to share them, and working with every level of organization to do that, and making sure every organization is heard, so we maintain broad representation and feasibility for all communities. London, I see you have a hand up.
Hi, yes. So my question was, as far as the coalition with the roundtables, how often do they usually meet?
Thank you, London. So this is our launch. We have not yet put together the leaders for the roundtable. We really encourage everyone here, and also when we share the recording, and we'll reach back out on email to all the other more than 100 people who've voiced interest in this. We need people who are willing to say, I'll roll up my sleeves even a little bit more than other folks, so I'm willing to help lead it. And through that, London, we are going to want to make our own efforts be pragmatic. So I don't expect we're going to be having roundtables meet in and of themselves very often, but there could be work groups that spin off from this, knowing that largely when we're talking coalitions, we're talking volunteer efforts. It's going to be all about what's realistic for everyone, but also with clear deliverables, clear outcomes, and clear goals. And the overall organizational leads will attend to that as one of the key metrics. So yeah, thank you for that. We want this to be workable for everybody.
As an educator in facilities and research in facilities, I agree with there. It's hard to get them to participate, and I think there should be encouragement of a way of them doing it, not in the facilities, maybe even set it up as CE, free CE that they get for their licensing and things like that, as well as it, like I believe it was, it's not all about just understanding the techniques, it's about understanding the people, the body language, the way the disease works, and understanding that task oriented. When I'm educating these people, they're so short of help. It's all about getting the task done, and they forget the individual. And then I have to show them that if they start out with the individuals and understand the individual, the task actually becomes shorter, and it's easier going, and it works better. And more of these facilities that I'm going into have what we call memory care lockdown units, and they are needing more and more advanced care and need more advanced staff taking care of them.
Pat, thank you.
I would love to help out the group.
Thank you. And I'm seeing some people in chats who are coming out. So Pat, again, perfect example of why expertise is going to be important to this. Yes, if people who are interested in participating in a work group and leading in a work group, please feel free to put that in chat. As I said, we're also going to send out an email so that we make sure to everyone who already registered, which can also be shared more widely, that you can respond that way. We've got 2 minutes. Any other comments from anyone who hasn't had a chance to share perspectives or thoughts before I
can't seem to raise my hand in the Zoom, so I'm doing it in real life. Hi, I'm Elizabeth Malloy. I'm a geriatric care manager, LCSW in Los Angeles, and I also have a father in a very nice assisted living in Washington, DC. So I'm kind of a consumer, and I'm also kind of a participant. And over the years, I've had many clients in many different assisted living communities and board cares and skilled nursing. And we really do see a lot of what goes on. And, and families, I think, they're very blind of what happens in these places. It's not all bad. It's just that there's no real representation for the residents. And it's just a constant, I'm always feeling like I see more than one family member will see. A family member might note that their mom's served tomatoes when they're not supposed to be served tomatoes. And, that's like a one-time thing. It's not a problem. But if it's happening, or if something else like that, or medication issue is happening across, the entire staff, no one really sees or advocates for it. And I've written down so many thoughts about improvement or the future. So I'd love to participate, but also, one thought that came up when I heard you, Cheryl, on the Jerry Powell podcast, plug for my favorite podcast, is that having maybe some kind of advocacy panel that's not the ombudsman, but some sort of group that is allowed to, for especially families that don't have anyone in town, that's some sort of a resource that has people who are visiting, have eyes and ears on residents. I don't know. That's just sort of a thought I had that could be something that would be one way to address families that don't have anyone there. Because we all know that helps people's experiences when there are family members coming in and out, being friendly.
Thank
So,
you. Excellent.
Thank you so much.
And I love that you can make it, Elizabeth. Thank you. So I will wrap us up. I mean, already, as we're all hearing, there's already not only energy, but a lot of great concrete suggestions. So out of respect for everyone's time, I will wrap us up. I will thank you all on behalf of the panelists, the organizations who have already been moving forward on this, for everyone being here, for the work that you're all doing. You look around, this is not only the who's who, it's the people who are making all of this happen and affecting change and promoting and making quality. So thank you. This is going to be the beginning of a long, productive, and successful relationship. Thanks all for being here, and we'll be back in touch. Happy holidays and New Year. Bye-bye.